Okay, when we talk of activity in cardiac cells, of course, we refer to both electrical and mechanical activity. They are coupled in cardiac cells. And action potentials, of course, represent the electrical activity not only of cardiac cells, but of all excitable cells, including neurons, skeletal muscle, smooth muscle, etc. Let's now consider a ventricular cell. Now, ventricular cells have a resting potential of about -90, -80, -90 millivolts. And the action potential initiates with a fast depolarization, which is due to the entry of sodium ions. The entry of cations, so positively charged ions, represents a negative current and is therefore linked to a depolarization. The action potential lasts for about 200 milliseconds. It's a very long action potential in the heart, and during this time calcium ions enter the cell and cause contraction. This is the most important mechanism for excitation, contraction, coupling. The action potential then terminates because of this repolarizing process. This is a hyperpolarization, and it's due to the increase of a potassium current. So there's an outward current now causing this phase, so hyperpolarization is linked to an increase in an outward current. Okay, ventricular cells are excitable cells, of course, but they're not pacemaker cells in the sense that they're not able to generate spontaneous activity. So this is the resting potential about -90 millivolts or so, and only when there's a trigger, which usually is a stimulus coming from a neighboring cell, then if the stimulus arrives and gets up to about -50 millivolts or so, does the action potential generate, and activity requires the stimulus for neighboring cells. On the other hand, the pacemaker cells in the sinuator node, the situation is very different, and at the termination of an action potential, the membrane voltage doesn't go as negative as in ventricle cells, so it stops at around -60, -65 millivolts. And then there's this diastolic, slow pacemaker depolarization. It's a process that brings slowly the membrane voltage up to threshold for another action potential, and is therefore responsible for spontaneous activity. Okay, Purkinje fibers also have a diastolic depolarization phase in the sense that they are capable of spontaneous activity. And when I was in Cambridge, I worked on the mechanism that was thought to be responsible for this phase. This was the IK2 current, so-called pacemaker current, and it was believed that this diastolic depolarization depended on a decrease of the IK2 current during diastole. The IK2 current, you can see a few traces here, was described as a potassium current activated on depolarization and deactivating on hyperpolarization. So this is a deactivating outward current, and the fact that it is a potassium current relies upon the fact that the current had a reversal potential around the expected potassium equilibrium potential. Although it was a bit more negative, this was already something that suggested that there was a problem. And this, however, was a real landmark in cardiac electrophysiology. The pacemaker process was thought to be therefore due to the decay of IK2 during diastole, and this mechanism was very well established and accepted as a major dogma in cardiac electrophysiology. In 1977, I then moved to Oxford from Cambridge and to work in Dennis Noble's laboratory. This is Dennis Noble, this is Carlos Ojeda, David Eisner, David Atwell, John Lederer, and I started to work with Susan Noble and Hilary Brown in room 15. These were 1977, the very first month this was a setup in electrophysiology. And Susan Noble, Dennis Noble's wife, and Hilary Brown were the two members of Dennis Noble's team working on pacemaker tissue. But that was amphibian pacemaker tissue in the sinus venosus of the frog. And I actually was very determined to work on the mammalian sinus because that I believe that was an important progress to achieve. And there was only one group, in fact, who had been able to voltage clamp the pacemaker, the mammalian pacemaker, the sinuator node of the rabbit. And this was a Japanese group. And incidentally, one of the members of this Japanese team was working in Germany, Homburg-Saar, in Wolfgang Trautmann's laboratory, and this is Aki Noma. And I managed somehow to get an invitation to work in this laboratory for a few months to learn how to voltage clamp the sinus node. This sinus node preparation was actually a very demanding protocol. Very small strips of sinus tissue had to be cut off the sinuator node of the rabbit. You can see an example in this slide. And very small pieces, and then through ligatures done by with silk threads under the microscope, we had to produce very small, very tiny bits of tissue that was alive, was beating spontaneously, and impale this little bits of tissue with 2 microelectrodes and obtain stable recordings. And that was a demanding preparation. But this allowed to apply the voltage clamp technique and to investigate the ionic currents passing through these cells. When I was working in Homburg-Saar with Aki, we were working on potassium currents activated by depolarization, so we explored the depolarized range of voltages, and we did not normally go very negative with a voltage step. However, as it often happens in research, discoveries are made in part by choice and in part by chance. And so by chance, we happened at one point to give a more negative step, and I saw the development of this large transient that could be either an inward current increasing or an outward current decreasing. And since I had just been working on the IK2 current in Purkinje fibers, I was very curious to understand what this was, and I exclaimed, but this is IK2. Actually, it was not IK2, because if we kept on hyperpolarizing and applying more hyperpolarizing, higher hyperpolarizing steps, we did not observe any reversal, so this could not possibly be a potassium current. That was the first time I happened to see what had to become the funny current. The existence in the sinuator node of a current so similar to IK2 and yet different from it made me extremely curious. When I returned to Oxford and I brought back the voltage clamp technique of the sinuator node, I started to actually investigate the hyperpolarized range of voltages, the range of voltages where diastolic depolarization occur. Indeed, at that time, all various investigations in sinus node and in other cardiac preparation had involved depolarized range of voltages, and nobody had really investigated the range of voltages where diastolic depolarization occurs. So it soon appeared that the current that we could observe by applying hyperpolarizing steps, this is the inward current that increasing during hyperpolarization, had very, very strange properties. For one, this was the first example ever recorded of an inward current activated on hyperpolarization. All of the inward currents known from the literature were activated on depolarization. And this was a really funny feature. And so we decided to call this current the funny current. Still, we soon found with great excitement that these properties of the funny current were very, very intriguing indeed. We made 2 important observations. The first one is shown in this slide was that the current was activated during voltage clamp in a voltage range which included the range of diastolic potentials. You see, in this case, there is a superimposition of action potentials and voltage steps applied to the same cell, and you can see that the current is activated within the range of diastolic potentials. Since the Fanny current is an EWA current, and EWA currents, as we have seen before, give rise to depolarizations, then we thought that this current could be responsible for the diastolic depolarization phase. So we thought that we could have found the pacemaker current for the sinuator node. But the second observation we made was even more striking. Everyone knows that adrenaline accelerates the heart. And acceleration usually involves the diastolic depolarization, whose steepness is increased in the presence of sympathetic stimuli. So we thought that if the Fanny current was important in generation of this phase, it could also be important in controlling its rate. And we were very curious to see what was the effect of adrenaline on the Fanny current. Well, we were very excited to see that indeed adrenaline increased the Fanny current in the EWA direction very markedly, with an effect that, of course, by increasing the EWA current available during diastole would act on an increased slope of the pacemaker depolarization. So these were really landmark novel data which established a new dogma for pacemaker activity. Pacemaking was not generated, as in Purkinje fibers, by the decay of an outer current, but by activation of an EWA current. Not only, the Fanny current also controlled the rate of diastolic depolarization, hence the heart rate, and was responsible for the adrenergic modulation of heart rate. Well, these first findings were published in 1979 in a Nature paper and were followed by several studies then in the following years. Now, there remained the issue of the IK2 current. How could I solve the puzzle of the IK2 current? Was it really possible that in the same heart, the process leading to pacemaker depolarization was so different? A decrease of a potassium current in the Purkinje fiber and an increase of IF in the sinuator node. The solution was simple. There was no puzzle because the two currents were indeed identical. IK2 had been incorrectly interpreted for some 13 years as a pure potassium current, but it was in fact the same as the Fanny current in the sinuator node. How could an EWA current become an outward current? Well, this was due to an artifact. The depletion of potassium from the extracellular spaces gives rise during a hyperpolarizing step to a transient, an EWA decreasing transient that overlaps the activation of IF and gives rise to a time course of the current that appears to create a reversal. So the illusion had been created by an artifact due to depletion of potassium ions from extracellular spaces during a voltage clamp recording of IK2 in Purkinje fibers, creating a fake reversal near the expected equilibrium potential for a potassium current. Once this depletion was removed by, for example, addition of barium, then the IK2 type of behavior could become an IF type of behavior. This is the same Purkinje fiber in the absence of barium. In the presence of barium, you can see that the current does not reverse anymore. There's no reversal at very hyperpolarized voltages. So this is exactly IF, and we are here in Purkinje fibers. So these results establish that IK2 was a camouflaged IF, and the two pacemaker currents were actually the same in two different cardiac tissues. This paved the way for an integrated view of cardiac pacemaking in different pacing regions of mammalian heart. Well, a lot more data have been collected on the finding currents since these original findings. For example, in the mid-80s, it was possible to isolate single cells from the sinuated node and apply the patch clamp technique, so only one electrode could be used rather than two electrodes, and this allowed the recording of action potentials and, of course, of the finding current by hyperpolarizing steps. This was an important improvement because it allowed also the investigation of single channel properties of the finding current. For example, we know that they are regulated by the autonomic nervous system. This is important because the finding current not only is responsible for generation of spontaneous activity, but it's also responsible for rate control by the autonomic nervous system. This cartoon summarizes the situation and the control of rate mediated by the finding current, control of rate by the autonomic nervous system. Under normal conditions, finding channels are responsible for generation of this diastolic depolarization and control rate. When the sympathetic stimulus is applied, so adrenaline binds to beta receptors, then there's a cascade of intracellular events leading to an increase of cyclic MP. Cyclic MP is a second messenger in the control of finding channels, in that it binds directly to finding channels and activates them by shifting the activation curve of these channels to more positive potentials. This increases the fraction of channels that are open at any potential. This also implies that there will be more inward current available during the diastolic depolarization. But since inward current means that it's a depolarizing process, increasing the inward current will increase the speed at which depolarization occurs. And of course, this gives rise to acceleration because we have more inward current during diastole. This is why our heartbeat is accelerated in the presence of adrenaline. On the contrary, when the parasympathetic stimulus is applied, so acetylcholine binds to the muscarinic receptor, the opposite set of intracellular events occurs. There's a decrease in the cyclic MP content, fewer finding channels are activated, and this decreases the inward current during diastole, and as a consequence, slows the rate of diastolic depolarization. This gives rise to slowing of the rate. So finding channels are responsible for the autonomic modulation of heart rate. A third application, possibly the most important one at present, concerns finding channels viewed as pharmacological targets for the control of heart rate. It is long known that slowing of heart rate is beneficial in the treatment of several pathologies such as angina, heart failure, ischemic heart disease, and lowering heart rate is known to decrease the oxygen demand and to improve myocardial perfusion during diastole, and therefore improves the oxygen balance. Incidentally, it is also known that elevated heart rate and mortality are linked. So it would be useful to develop drugs able to slow heart rate. Drugs used so far for bradycardic actions, calcium antagonists and beta blockers, unfortunately have also adverse side effects, such as particularly a reduced inotropism. So it would be extremely desirable to have a drug that is able to slow heart rate specifically without any side effects. Indeed, the relevance of defining current to generational rhythm and rate control makes it an ideal target for the development of such a type of drug. And several heart rate reducing agents have been developed. And all these drugs actually act by blocking Fani channels. Only one of these substances, ivabradine, has completed clinical development for angina and is now commercially available. And we know that the viability of ivabradine for clinical use has been amply demonstrated, and it has been shown that its rate-reducing action is entirely attributable to a specific and selective inhibition of IF. I repeat, the viability of ivabradine for clinical use has been amply demonstrated, and it has been shown actually that its rate-reducing effect is due to a inhibition of the Fani current. Ivabradine inhibits specifically the Fani current, and this reduction, of course, will impact on the slope of diastolic depolarization because we have less current available during this phase, and this gives rise to a very well-controlled slowing of heart rate. Ivabradine acts intracellularly and is called an open channel blocker. It has to cross the membrane and enter the pore of the channel from the intracellular side. This is why it's called an open channel blocker. Since it has to enter the channel from inside, and the channel must be open, the binding of the drug to its blocking sites needs hyperpolarizations. At the same time, the molecule is positively charged. It carries a charge of about 1. And therefore, this gives rise to a dependence of block upon depolarization. In other words, when the membrane is depolarized, then the molecule is pushed within the pore because it tries to go out of the cell, and this helps the binding and the blocking. This appears to be a contradiction, but it is not. In fact, it can be shown that the higher efficiency of block occurs when the channel is cycled through a series of repeatedly through open and closed states, and the higher efficiency of block is obtained when there is an elevated rate of cycling. This is very advantageous because it means that the efficiency of the drug will increase for elevated heart rate rather than in bradycardia.